Good afternoon, everybody. And thank you for attending this great presentation. It's going to be a great wealth of knowledge. We've been waiting for this since earlier. We had to reschedule it to this afternoon about the lingering effects of COVID-19 on health benefits and workers' compensation insurance. We have with Insurance of America, Alexis DeLuca and Rick Neyman. We're going to be presenting together. They're socially distancing, so that's good. We're going to start the Keep in mind that I'm going to put the survey link below in the chat bar, and also I will be putting anybody who's trying to be in this course for credits, you will see the credit words inside of the chat. Without further ado, I'll let you guys take the show.
Awesome. Thank you, Prince.
You're welcome.
All right. So today we'll start off just briefly. We'll do some short introductions about IOA and who it is that'll be presenting. The first half of the presentation will focus on the employee benefit side and how COVID is impacting there. And the second half will focus primarily on workers' comp. So who are we? Well, we're with IOA. IOA is the largest independent insurance, employee benefits, and risk management concern in the state of Florida. We're the 10th largest such firm in the US. So we've got partners all over, 300 partners, 1,300 employees. We're an ESOP, 75 offices around the US, 2 in the UK, and we're a fast-growing, organically growing firm. And speaking to you, to my left, your right, is Alexis DeLuca. Alexis is the managing director for IOA's employee benefits practice for Southeast Florida, and I am the managing partner of the West Palm Beach location, and my specialty focuses more on property and casualty. The first part of the presentation will focus on employee benefits, and I'll turn it over to Alexis.
All right, thank you, Rick. So we're going to talk today about some of COVID-19's lingering effects, give the play there on what is a serious disease. But really what I want to focus on with this presentation is what's next for employee benefits following this COVID pandemic. And that's the reason for the title. So we're going to talk about the ongoing cost effects, some of the virtual workforce effects that we're seeing, and of course, the compliance effects. So the cost effects, a lot of times we automatically assume there's a health pandemic. This is going to be terrible for the health insurance companies. It's going to be a disaster for their profitability. But we started to see headlines in the third quarter of 2020 announcing record health insurance company profits in the middle of this health pandemic. So what gives? What's happening there? It's very counterintuitive to be hearing that the insurance companies are doing very well and exceeding their profit expectations with what's happening from the health side. But what we're seeing is it's all about utilization. At the end of the day, that's always at the heart of insurance pricing, and 2020 is no different. There's actually been an underutilization of services in 2020 because of the healthcare pandemic. The reason being, we saw many states shut down non-essential or elective procedures. Some states are still shut down for elective procedures or back shut down for elective procedures. That actually closed many doctor offices and even portions of hospitals where those workers were focused on procedures that were no longer happening. So it was a bit of a surprise to everyone that healthcare workers and healthcare businesses were actually some of the hardest hit by the COVID-19 pandemic. Again, you might have had within a hospital system some areas doing well and having a lot of patients and a lot of care flowing through, and yet still entire floors of that hospital empty. So what this is doing is creating an expectation for overutilization for possibly 2021. It's difficult to predict, but the suppression of care from 2020, the fact that many people are not receiving services that they don't deem critical, is expected to create a dramatic increase in care in the future. Medical costs could balloon to 10% higher than pre-pandemic levels. That's what some are expecting. And of course, the big concern in the industry is that today's delay in care is going to result in a more intensive medical intervention in the future. So something that someone might have had treated in 2020 with simple medication may now result in a surgical procedure by the time they seek care in potentially 2021. And that timeline is still fluid. A vaccine could speed up the predicted wave of pent-up utilization. If massive vaccinations are complete early in 2021, we might see that hit very soon. The opposite could be true. If the virus continues to circulate at significant levels, many people may continue to forego care. And so we may actually not even see this overutilization hit until 2022. So what's the point? It's difficult to price for medical care right now. If you were to look back at what was happening in March of 2020, the outlooks were dire. Everyone was expecting dramatic rate increases in order to address the expected lower profitability by the health insurance carriers. And so when this was first starting, everyone thought, oh no, this is going to be bad for our employer-sponsored plans in their rates. Come July of 2022, we saw that impact was, becoming a little bit more moderate. They thought it might be a +3 to +4.5%. Could end up being what employers might see once the pandemic began to clear and we started getting our rate increases. But by October of 2020, there's now a prediction that average costs are going to actually decrease for some employers. And the upward side of the increase is really not any worse than what was first expected back in July. So from March to July to October, we've seen a very different expectation with how this will translate into pricing for employer-sponsored plans. We're also seeing a difference, small group versus large group. Now, in this case, I'm defining small group as groups who have fewer than 50 employees because their pricing is different. Small groups that renewed already, but in the second half of 2020, have likely been the ones to suffer the biggest hits. That is because pricing for groups under 50 is filed in advance with the state. So for example, the state of Florida already approved third quarter 2020 pricing back in earlier 2020, January, February, March, even April. Once it's filed with the state, it can't be changed. So once that was set, that's set. And some of these rates were getting developed as the pandemic was first evolving, and the pricing impact was expected to be much greater. So that's why I say some of these smaller groups kind of got harder hit when they renewed because they were potentially entering at pricing that was already expecting a worst case scenario versus pricing that's being developed in the latter half of 2020, where the expectations are more moderate, and therefore it's not having quite as big an impact. Now, large groups have more flexibility with their pricing. They can negotiate, they have their own claims influence things, and carriers on the spot can choose to invest some of these extra profits into a group and therefore make the rates a bit more competitive. So we're seeing a very different impact on those large groups where there's some flexibility. I should add that if you guys have questions along the way, go ahead and put them right in the chat box because we will have time for Q&A later. But the impact has definitely been less severe from the pandemic specifically. So when we're looking at what this is going to mean for health insurance rates, it's not good, but it's not as bad as first expected. But we're likely to see a lot of continued volatility in pricing because the underwriters are going to continue to adjust expectations as we continue moving through the pandemic and whatever impact it will have. So my takeaway for everyone here, if there's one thing that you walk away from, challenge everything. In my 20 years, I am seeing carriers do things I never would have anticipated. So don't take anything for granted right now. Throw out the old handbook. It's a whole new world right now, and there's a limited window where you can take some opportunities and turn that into your advantage. So don't assume anything is a given because that's how it has been for many years prior. Right now, everything is new and impossible. Another thing that I think we should brace for, and I would warn you to brace for, is what this is going to mean for networks and network contracting. As I mentioned, healthcare providers were some of the hardest hit by the stoppage of non-essential or elective healthcare. a lot of the heavy cost related to COVID-19 is hitting the Medicare market. Now, Medicare reimbursements are already supplemented by private insurer pricing. That means employer-sponsored plans who are purchasing through, the Blue Crosses, Cignas, Uniteds, Aetnas, Humanas of the world. Medicare only reimburses about 80% of the actual cost of care. So the rest is made up for by the private insurance market. When you think about the fact that Medicare is the one covering the majority of heavy cost related to COVID-19, as you can imagine, the delta that's going to need to be made up for by the private insurance market is going to be larger in the future. And we've already seen increasingly public contracting battles. I'm sure everybody listening today has gotten a letter from, a provider's office that, hey, we're in negotiations with, XYZ carrier. And as of this date, we're going to be out of network. They've already begun going very public as they renegotiate these provider contracts. And I don't see that going away, particularly as these negotiations heat up when the contracts come up and they need to make up for some of these losses. So things to think about ahead of time, start asking those questions, asking the questions of your employees and yourselves in your entire business. Do you really need the largest network with the most access points? It might be what we all like and what we want, but do we need it? If we have 350 primary care providers within 10 miles of our primary zip code, is that sufficient? Or do we really need 1,300? Can you prepare employees for losing some of these larger provider practices? Is there some groundwork that you can lay in case you end up choosing to make a choice for a smaller network at some point in the future? And of course, can you get involved in applying some of the pressure when these things come up and these contracts go public that they're in negotiation? Are you in a position where you're willing to, place some calls to the providers, place some pressure on the carrier about what is and isn't the most important about things? Okay. One thing I want to shift to, and remember, we will have a Q&A, so we'll go through any questions that get submitted in the chat box at the end of the presentation, okay? But continue to submit any of the questions that you have in there now, and that way we can get to them later. But I want to talk about the virtual workforce that we're seeing happen. So in a lot of businesses, all or some of the employees have gone fully virtual. And so they're no longer, in a brick and mortar building. And I'm hearing from some HR that they're viewing this as a recruitment opportunity because suddenly they don't necessarily have to recruit from the local area. They can actually, if they've found that certain positions are translating to a full-time remote position well, they can hire from anywhere for somebody to do that role. This is being seen as a real positive with respect to, talent and the talent you can bring in and recruit. But this does present some issues for the health plans, like network access. So once you start hiring outside of the local area, do you have plans and networks that have availability where some of those virtual or remote people might be? And if you do have, let's say, the traditional HMO and PPO dual option that's common in South Florida, how will you price for the PPO if that's the only option available to those remote employees? Some employers will not charge the same as they do to an employee who has a choice between two plans. So that's going to have an impact on your net cost pricing and what type of adjustments you might need to make when you're looking at hiring somebody remotely. Also, you may start running into state mandates. If you're fully insured, you have to comply with each state's mandates with your health plan. So as or if you begin to expand your workforce out of state, these things might start to apply and may take on a role in what your health plan looks like for those folks. So I just put up two examples here. Some states actually require coverage for bariatric surgery. Florida does not. So most standard fully insured policies issued in Florida are going to have that excluded. But if you hire someone in a state that requires it, then that person will have to have that added to their certificate of coverage. There are also states that do not require full diabetes coverage. They do cover a lot of things related to diabetes, but we wouldn't call it exactly comprehensive. Now, your plan is going to be issued out of Florida, and it might automatically include all that full coverage, but that will make it a little bit more generous or maybe advantageous to folks in certain states. So it's just the fact that as you move about or hire people virtually and outside the local area and potentially outside of the state, you may see some slight differences in the details of what's covered and not covered. Massachusetts is a fun one. Anyone who has had employees in Massachusetts knows they have their own set of creditable coverage rules that are not aligned with the Affordable Care Act rules. So when you have more than 6 employees in Massachusetts, a whole bunch of new requirements kick in, specifically with reporting, exact terms on your plan design, and individual employees in Massachusetts are actually still subject to state taxes relative to an individual mandate in that state. So if you just have 1 or 2 folks there, just be aware that the individual employees are actually subject to some state tax rules, but the requirements on you as an employer really kick in once you have 6 people there. And then Hawaii, we had a group who approved for an employee to go full-time remote from Hawaii because, hey, if we're going to work at home, we might as well do it someplace stunningly beautiful, right? They thought this was great. They kept the employee. He was happy to get to move there. Well, then they learned that Hawaii only allows certain admitted carriers. So you can't just have an employee decide to move to Hawaii and work 100% remote and still be enrolled in your Cigna policy that the rest of your US employees are enrolled in. If it's not one of the approved carriers and approved plans, you have to go purchase a specific plan just for that Hawaii employee. So there are a couple of states around that still have their own unique little criteria. So before you agree to somebody relocating, you definitely want to ask those questions and make sure that you're not going to run into some complications. This also, of course, presents some logistical questions. What's your enrollment process like today? Can you do it virtually if you haven't already moved to virtual? We're certainly seeing this drive the need for web-based enrollment applications much more than in the past. And of course, an increased need for digital materials and being able to communicate everything with your employees in an electronic fashion. But do not forget, if you start shifting to electronic communications for your benefits, you have to have proper documentation complying with the Department of Labor's electronic disclosure rules. Employees still have to have regular computer access as part of their job in order to simply communicate electronically only. A kiosk that multiple employees can access actually does not satisfy the requirements. And if you have employees sign off that you can send the materials to their personal emails because perhaps they don't have a work email address or regular work access to a computer, you can absolutely do that. But there are still some suggested best practices about making sure they're notified when something has been made available electronically, sent to them or posted in an intranet site or something along those lines. So the electronic disclosure rules, they did some updating of them, the Department of Labor did, but not relative to ERISA and its documents. So we're still working under some pretty old-fashioned electronic disclosure rules. So be careful with that one. Also, there was some early legislation, of course, the CARES Act, the Families First, things like that we saw that really expanded a lot of things in our health programs, which is great, but don't forget about those plan amendments. There were special COVID-19 related enrollment changes. So some of the carriers said, hey, it's a pandemic, and if you had employees decline enrollment during annual enrollment, and now they want to take health coverage, we'll permit it. If you chose to allow any of those COVID-19 related enrollment changes, you still have to make sure that you amend your Section 145 or premium only plan document to permit it. Same with COBRA election and payment deadlines. They extended the amount of time an employee can elect COBRA and pay the premium. Make sure your plan documents are amended, particularly important if you are self-insured. Stop loss policies are usually blanket coverage over the existing plan document. You've got to make sure your plan document is accommodating these extra time frames. and lots of changes on 125. So if you have a flexible spending account program in place for your business, make certain that your plan administrator is updating all your documents, because a whole bunch was needed here. They extended the grace period for FSA claims. They increased the carryover amount people are allowed to bring. Over-the-counter medications without a prescription was brought back, which everybody's very happy about, but you better make sure your plan document says that's okay. And claims run out is extended to sometime after the outbreak period. That is actually what the rules say. That has yet to be defined. So could be quite some time before people are actually required to have submitted those claims. So that wraps up the benefits employee part. We're going to talk about workers' compensation. And again, we'll come back and do questions and answers as soon as we wrap up. So here's Rick. He's going to lead you on workers' comp.
All right. Thank you, Alexis. If you haven't already realized, Alexis's knowledge on matters of employee benefits is encyclopedic. She is the only person I know who actually read the entire ACA. She read it within weeks of it actually being published. So if you do have questions pertaining to employee benefits, regulation, things of that nature, she's a phenomenal resource. So keep her contact, and I know that she would be delighted to help out. So part 2, workers' comp. So what I'm going to try to cover in the time we have allotted, I'm going to try to gloss over this. Prince, I don't know if you can speak. I'm looking at 142 right now. Maybe send Alexis a text when we have a hard stop so I can pace myself. But what we're going to cover today is, I think any discussion of workers' comp, you begin at the beginning. I don't want to presuppose folks understand workers' comp and what the background is there. So I'm going to start with the scope and intention of workers' comp, what it was meant to do. We're going to talk about COVID compensability comp in the news that a lot of disappointed and surprised to find out they don't have business interruption coverage for COVID. They thought and was shut down. They had no coverage. There are definitely some coverage issues around COVID when it comes to workers' comp, and we'll talk about that. We're going to take a look and examine the actual claims that have been submitted, have been paid and denied in Florida under COVID. We're going to talk about OSHA and COVID. Any discussion of workers' comp would probably be incomplete without touching on OSHA, as they're very closely related. And I'm going to take a minute or two and throw in a that are assigned to every different class code, and some premium issues that are going to be unique to COVID and how that's going to be handled. Things on your radar for the future, and things that we can start to prepare for now that may become problems or issues down the road. A little bit of preparation, mitigate challenges you might run into, up with some useful links.
Rick, didn't want to interrupt you. Can you hear me? The signal is coming. Yes, your signal is coming in slowly. Just give us like a quick second, okay? Make sure they can hear you.
Okay.
It was working smoothly, but as soon as you came on, you're too hot for the camera. Hold on one second.
Okay, so maybe what we'll do at this point is we'll take a second to address technical matters. We do have another session starting at this time, which is the 2021 payroll and tax law update provided by Romeo. So maybe if we can have folks heading over in that direction, we'll spend a minute ironing out these technical issues, and we'll have a follow-up to lingering effects in just a short amount of time here. Quick, we could patch everything up.